that's just to allow us easier streaming and to record the webinar for sharing afterwards. If you do have any questions that you would like to ask Dr. Namba, Dr. Fumi, we will, you can use the Q&A function and we will field those questions afterwards. If you want to say hello to anyone else, if you want to let anyone know where you're dialing in from this morning, you can type into the meeting chat for that purpose. So just to introduce Fumi, first of all, so Dr. Fumihiko Namba is a neonatologist and also professor in pediatrics working at Saitama Medical Center in Japan, which is one of the largest neonatal intensive care units in Japan, located just outside Tokyo. He's been involved in numerous research projects related to preterm diseases, and specifically looking at things like BPD and retinopathy of prematurity, and has been widely published. We're really, really delighted to have him speak to us today. I've had a little bit of a sneak peek of his presentation, and it is fantastic and really, really educational. Just before we get started, we do like to get to know our speakers a little bit better. So I have some casual questions to ask Fumi before we get started, just to get to know him a little bit better and break the ice as such. So Fumi, when you are thinking of your day-to-day, would you be an early bird or a night owl?
Thank you for your question. I'd say both. I wake up at 5 a.m. because my commute to the hospital takes about 1 hour and a half. But at night, I still enjoy watching American TV show on Prime Video, sometimes until midnight, so always sleepy.
Yes, you must be able to run on very little sleep. Thank you so much. Maybe a food question now, sushi or ramen?
10 years ago, ramen, no question. But now that I'm in my 50s, so it feels a little heavy for me. So unfortunately, I have to choose sushi now.
Yes, that's very wise. If you weren't a neonatologist and you had another job, what would your dream job be?
The answer is MLB player, Major League Baseball player like Ichiro, Matsui, or Otani. I grew up watching baseball, so that was always my dream.
Very good. Maybe just one last question. What inspired you to pursue a career in neonatal care?
Honestly, neonatology was not my first choice. My professor decided for me, but once I started, I realized how many unknowns there are in this field, and I really enjoyed both the clinical work and the research. The best part has been meeting colleagues from around the world and being invited to speak at a meeting like this. So hopefully not a webinar, but in person next time.
Yeah, that sounds great. Thank you so much for answering those questions and letting us get to know you a little bit more. So I'm just going to pass over to you now if you want to share your slides and your presentation, and we're really looking forward to learning from you and your experience in Japan. Thank you.
Good morning, good afternoon, and good evening. Thank you for the opportunity to present our experience with the management and outcomes of periviable infants born at 22 and 23 weeks of gestation in Japan. Japan has developed a distinctive experience-based approach to periviable care. I will focus on both survival and long-term outcomes. In 2023, a baby boy due was born by cesarean section at 23 weeks of gestation. This scenario is not uncommon in our NICU. Since 2003, we have actively resuscitated infants born at 22 and 23 weeks of gestation. This case reflects a scenario we encounter repeatedly. I will use Liu's course to illustrate real-world decision-making. As some of you may know, in 2023, we published a single-center report in the Journal of Perinatology describing the management and outcomes of 29 infants born at 22 weeks of gestation. This publication triggered many international questions, especially about practical bedside management rather than only statistics. Following the publication of this article, we received an increasing number of inquiries regarding the care of extremely preterm infants, particularly those born at 22 weeks of gestation in Japan, not only from colleagues and friends, but also from centers across Europe, the United States, Oceania, and South America. What surprised us was how broad the interest was across continents. This suggests that periviable care remains a global challenge. What is the standard of care for these infants in other countries? The following table summarizes recommended resuscitation guidelines for infants born at 22 to 24 weeks of gestation in major industrialized countries. In Japan, however, no national guidelines have been established, and resuscitation policies vary widely among NICUs. A recent survey showed that approximately half of Japanese NICUs actively resuscitate infants born at 22 weeks of gestation. As mentioned earlier, our center has provided active resuscitation to all infants born at 22 weeks since 2003. Please note that standard of care differs depending on national policies and whether active resuscitation is offered at 22 weeks. What are the survival rates of infants born at 22 weeks of gestation who undergo active resuscitation in different countries? This slide summarizes survival rates reported since 2000. As shown, recent survival rates for actively resuscitated infants born at 22 weeks are approximately 40% in Europe, 30% in North America, and 70% in Japan. The most recent survival rate in our NICU was 83%. In 2025, Isayama and colleagues reported survival outcomes of infants born at 22 weeks of gestation across 11 neonatal networks. Survival in Japan exceeded 60%, which was substantially higher than that reported in other countries. This multi-network analysis provides a valuable international benchmark and confirmed that Japan remains an outlier with higher survival. This slide illustrates survival rates of periviable infants in Japan since 2003, using data from the Neonatal Research Network Japan, which covers approximately 70% of all very low birth weight infants born nationwide. In Japan, survival to NICU discharge for infants born at 22 and 23 weeks of gestation has steadily improved. reaching approximately 60% and 80% respectively over the past 5 years. What factors may contribute to the higher survival rates of periviable infants in Japan compared with other countries? The improvement over 2 decades suggests a bundle of practices rather than one single intervention. This sets up the main question of today's talk. Today, I will outline the management of infants born at 22 and 23 weeks of gestation in Japan in the following order. I will move step by step from evidence to a real case and then to national practice patterns in Japan. I will first present the evidence informing the management of preterm infants based on clinical guidelines and systematic reviews, including Cochrane reviews. I will highlight where evidence is strong and where we still rely on experience, because data in 22-week infants are limited. Second, I will present a case illustrating how we managed baby Ryu, who was born at 23 weeks of gestation, across each stage of care. Case-based discussion helps connect the guidelines with real-life constraints in the delivery room and NICU. Finally, I will present current practices in the management of infants born 22 and 23 weeks of gestation in Japan, using 2 complementary approaches. First, I will share our single-center experience in managing infants born at 22 weeks in our NICU. Second, I will present the results of a nationwide survey of Japanese NICUs regarding the management of infants born at 22 and 23 weeks. Both studies have been published recently. The key goal is to understand not only what we do, but why we do it and how common these practices are across Japan. The first topic is umbilical cord management during delivery room resuscitation. Cord management is one of the earliest interventions and may influence both hemodynamic stability and the risk of intraventricular hemorrhage (IVH). Umbilical cord management can be categorized into 4 approaches. These include early cord clamping, in which the cord is clamped immediately after birth; delayed cord clamping, in which clamping is performed 60 seconds or more after birth; and cord milking. Cord milking involves gently grasping the umbilical cord and milking it several times from the placental end toward the infant. 2 techniques of cord milking are recognized: intact cord milking, in which the cord remains attached to the placenta; and cut cord milking, which is performed after the cord is clamped and separated from the placenta, and is commonly practiced in Japan. It is important to distinguish intact cord milking from cut cord milking, because the evidence and safety signals differ by technique and gestational age. One of the most influential RCTs conducted by Catheria and colleagues was a non-inferiority trial comparing intact cord milking with delayed cord clamping for the composite outcome of death or severe IVH in very preterm infants born at less than 32 weeks of gestation. As shown in the upper right panel, there was no significant difference in the primary outcome of death or severe IVH between the two groups. However, as highlighted in red, a key secondary outcome, the incidence of severe IVH, was significantly higher in the intact cord milking group, particularly among extremely preterm infants born at less than 28 weeks of gestation. This difference was not observed in infants born at or beyond 28 weeks. Based on these findings, delayed cord clamping rather than intact cord milking is recommended for extremely preterm infants born before 28 weeks of gestation. This trial reminds us that gestational age modifies risk. Even if the composite outcome is similar, severe IVH in the most immature infants is clinically critical. Recently, the Incubator podcast summarized the updates from the neonatal resuscitation program on umbilical cord management, although the recommendations can be complex. In summary, for preterm infants, delayed cord clamping should be performed whenever possible. If delayed cord clamping is not feasible, intact cord milking may be considered, except in extremely preterm infants born before 28 weeks of gestation. Importantly, intact cord milking should not be performed in infants born at less than 28 weeks of gestation. A simple rule is helpful in practice. Delayed cord clamping whenever possible, and avoid intact cord milking in infants less than 28 weeks. After delivery, you were transferred to the radiant warmer with the umbilical cord cut to a length of approximately 30 centimeters. His body was gently dried using soft gauze. The primary resuscitator then quickly suctioned his mouth and initiated bag and mask ventilation, while a second neonatologist simultaneously performed cut cord milking. In the delivery room, we need a method that can be performed quickly and consistently. Cut cord milking has become practical in many Japanese centers. At our center, cut cord milking is routinely performed in extremely preterm infants born before 28 weeks of gestation. According to our institutional report, cut cord milking was performed in all infants born at 22 weeks of gestation, and delayed cord clamping was not used in these cases. This reflects our center's protocol and experience. It is also a good example of how local practice may differ from international recommendations. What about other NICUs in Japan? According to our survey, approximately 90% of Japanese NICUs perform cord milking in infants born at 22 to 23 weeks of gestation. In most of these NICUs, cord milking is performed by a neonatologist after cord clamping, a practice known as cut cord milking. This survey result shows that cut cord milking is widely adopted in Japan, making it an important national characteristic. The following section reviews two systematic reviews addressing delivery room respiratory management in preterm infants. Next, I will move to respiratory management in the delivery room focusing on initial stabilization strategies. First, CPAP was compared with tracheal intubation for the initial management of respiratory distress in very preterm infants born before 32 weeks of gestation. A meta-analysis demonstrated that in this population, CPAP reduced the risk of death or bronchopulmonary dysplasia (BPD) compared with tracheal intubation. Many trials include infants less immature than 22 weeks. The key question is how far we can extrapolate evidence to periviable infants. Regarding surfactant administration, a Cochrane review reported that catheter-based surfactant delivery for respiratory distress syndrome in preterm infants reduced the risk of death or BPD, death alone, tracheal intubation, BPD, and severe IVH compared with endotracheal tube administration. Catheter-based surfactant is promising, but implementation depends on staff skill, infant stability, and local protocols. Returning to Reed's case, after initial back and mask ventilation, he was intubated with a 2.0 millimeter endotracheal tube at 7 minutes after birth, without an attempt at mask CPAP. Surfactant replacement therapy was then administered because of a high oxygen requirement. After his condition was stabilized, he was briefly touched by his mother and transferred to the NICU. In the NICU, he was placed on mechanical ventilation. A nasogastric tube and umbilical catheters were inserted. Necessary investigations were performed, and intensive care was initiated. In Rill's case, rapid stabilization was prioritized. Even short delays in ventilation can lead to instability in these infants. Consistent with Rill's case, at our center, all infants born at 22 weeks of gestation were intubated in the delivery room. The mean time from birth to intubation was 3 minutes, and the endotracheal tube size was either 2.0 or 2.5 millimeter. Surfactant replacement therapy was administered in the delivery room in 93% of cases. This slide summarizes our center's consistent approach, early intubation and early surfactant, in nearly all 22-week infants. What about other NICU in Japan? In 94% of Japanese NICUs, tracheal intubation is performed in the delivery room, either immediately after birth or once the heart rate and oxygen saturation have stabilized. Similar to our center, 62% of Japanese NICUs administer surfactant in the delivery room. Ultrasound performed by neonatologists is another distinctive practice that supports frequent physiology-based decision-making. Upon NICU admission, Liu underwent ultrasound screening performed by a neonatologist, followed by serial examination every 8 hours. Cranial ultrasound was used to assess the presence of IVH and the risk of IVH by evaluating blood flow in the internal cerebral vein. Echocardiography was performed to assess cardiac function and the patent ductus arteriosus status. Abdominal ultrasound was used to evaluate for abnormalities of the abdominal organs. These serial exams helped us detect early changes and guide management during the most unstable period of life. For infants born at 22 weeks gestation in our NICU, echocardiography and cranial ultrasound are performed 1 to 3 times daily during the first 3 days of life, and once daily from day 4 to 7. The first 3 days are critical. Our frequent images reflect the belief that early detection and adjustment may prevent deterioration. What about other NICUs in Japan? 88% of Japanese NICUs reported that neonatologists perform echocardiography more than twice daily during the first 3 days of life. This showed that frequent echocardiography is common nationally, supporting the idea that ultrasound-guided care is widespread in Japan. Next, I will discuss circulatory management, including incubator settings, fruits, and vasoactive support. Returning to Ryu's case, upon NICU admission, the incubator was set at 90% humidity and 39 degrees Celsius, with setting subsequently adjusted according to skin condition and body temperature. Total fluid intake was initiated at 80 ml per kilo per day and gradually increased based on ultrasound findings. As routine prophylaxis, 3 doses of indomethacin were administered to prevent IVH, and 2 doses of immunoglobulin were given to prevent sepsis. Dopamine was administered for 3 days from day 5 to day 7 to maintain adequate blood pressure. This case illustrates our approach: tight thermal control, careful fluid advancement, and limited vasoactive use when possible. This slide shows total fluid intake, incubator temperature, and humidity during the first 7 days of life for infants born at 22 weeks of gestation in our NICU. Total fluid intake is initiated at 80 ml per kilo per day. The incubator temperature is maintained above 38 degrees Celsius, and humidity is kept above 90%. These targets aim to minimize insensible water loss and maintain stability, which may indirectly reduce complications. As mentioned earlier, echocardiography is routinely used to guide circulatory management in the NICU, where dopamine and dobutamine are the primary vasoactive agents used at our center. In contrast, approximately 60% of Japanese NICUs report using a combination of steroids, dopamine, dobutamine, and volume loading to maintain blood pressure during the acute phase in more than half of infants born at 22 and 23 weeks of gestation. That highlights national differences in blood pressure management, including more frequent use of multimodal therapy in many NICUs. Now, I will focus on respiratory management after NICU admission, including a ventilation strategy and lung protection. After NICU admission, Ryu was initially supported with conventional mechanical ventilation (CMV). During the first 3 days of life, we were particularly concerned about the risk of IVH. After this high-risk period had passed, the ventilator mode was switched from CMV to high-frequency auxiliary ventilation HFOV on day 3 of life. Based on his respiratory status and with the aim of preventing BPD, caffeine and inhaled corticosteroids were initiated on day 2 of life, and additional surfactant replacement therapy was administered on day 3, 4, 7, and 14, for a total of 5 doses, including the initial dose given in the delivery room. 3 courses of hydrocortisone were administered, and oral duodenal tube was placed at 3 weeks of age to prevent pulmonary aspiration of milk. After extubation, nasal CPAP, followed by high-flow nasal cannula therapy, was used to support respiration, and respiratory support was successfully weaned by 36 weeks of postmenstrual age. The first 3 days are a fragile transition period with high IVH risk. After this, we shift our focus toward lung protection and avoiding ventilator-induced lung injury. This slide summarizes a Cochrane review evaluating HFOV for respiratory failure in preterm infants. Among infants born before 36 weeks of gestation, HFOV was associated with a reduced incidence of BPD and retinopathy of prematurity, but an increased incidence of air leaks compared with CMV. There were no significant differences between the two groups in mortality or IVH. HFOV may reduce BPD, but increases air leak risk. Therefore, it is a tool that requires careful settings and monitoring. The Hi-Fi trial, one of the earliest and the most influential RCTs of HFOV in preterm infants, reported a higher incidence of severe IVH compared with CMV. In contrast, as noted earlier, a more recent Cochrane meta-analysis found no significant difference in the incidence of severe IVH between HFOV and CMV. Historical trials raised concern for severe IVH, but more recent meta-analyses do not show a clear difference, supporting selective HFOV use. As mentioned earlier, all infants born at 22 weeks of gestation are intubated and mechanically ventilated during the acute phase in our NICU. Around day 4 of life, after the risk of IVH has decreased, the ventilation mode is often changed from CMV to HFOV. Other Japanese NICUs employ a similar approach. CMV, such as SIMV, is typically used initially and later transitioned to HFOV. After the first week of life, HFOV is used in approximately 60% of Japanese NICUs. The slide summarizes the typical Japanese strategies: initial CMV, then transition to HFOV after the first week in many centers. I will briefly discuss sedation and earlier, where practice often varies across institutions because high quality evidence is limited. After Liu was admitted to the NICU, phenobarbital was initiated for sedation, primarily to reduce the risk of IVH, and secondarily to stabilize his respiratory status, and was continued until day 7 of life. Phenobarbital was used during the acute phase in our case. This reflects a common Japanese practice aimed at stabilizing infants early. In 2023, a Cochrane review summarized the evidence on pharmacologic analgesia and sedation for the prevention of IVH in preterm infants requiring respiratory support. A meta-analysis of acetaminophen, midazolam, phenobarbital, opioids, and ibuprofen showed that none of these agents had a protective effect against IVH compared with placebo. This navigate finding is important. It reminds us that routine pharmacologic prevention of IVH is not supported by strong evidence. In the acute phase, phenobarbital is the primary sedative used in our NICU for infants born at 22 weeks of gestation with the aim of reducing the risk of IVH. During the first 3 days of life, more than 90% of infants receive phenobarbital sedation. In contrast, nationally, over 70% of NICUs report using sedation during the acute phase, with fentanyl being the most commonly used agent, followed by phenobarbital. This slide contrasts local and national practice. Even within Japan, fentanyl and phenobarbital are used differently across centers. Finally, I will conclude with 2 points on intestinal management, focusing on practices commonly used in Japan. Regarding juice nutrition, mother's own milk was initiated on day 2 of life and advanced daily by 10 ml per kilo per day, with fortification starting on day 11. Full enteral feeding was achieved by 2 weeks after birth. Probiotics containing bifidobacterium were started on day 3 to prevent necrotizing meningitis (NEC), and glycerin enema were initiated simultaneously to prevent meconium-related illness. This case showed a structured feeding advancement strategy and early adjunctive interventions aimed at NEC prevention and bowel function. First, probiotics are used to prevent NEC in preterm infants. As you may know, probiotics have been shown to reduce the risk of NEC and mortality in preterm infants compared with placebo or no treatment. Probiotics are one of the few interventions with relatively consistent evidence of benefits in preterm infants. In our NICU, probiotics are administered to more than 90% of infants born at 22 weeks of gestation, starting on day 2 of life, and continuing until a postmenstrual age of 36 weeks. Nationally in Japan, probiotics are used in approximately 90% of NICUs, whereas prebiotics such as oligofructose are rarely used. This slide showed that probiotics are widely used nationally, while prebiotics remain uncommon in Japan. Cochrane Review systematically evaluated the effects of glycerin enemas on nutritional outcomes in very low birth weight infants. The review found that glycerin enemas reduced the proportion of infants without stool for more than 48 hours after birth, but had no significant effects on time to full enteral feeding, length of hospital stay, mortality, NEC, or other major clinical outcomes. Glycerin enemas may improve stool passage, but do not clearly improve major clinical outcomes, so their routine use remains debated. At our center, glycerin enema are administered at least 3 times daily after the first 3 days of life, once the period of high risk for IVH has passed. Glycerin enemas are also commonly used in Japanese NICUs, although the timing and the protocols vary among institutions. Our practice delays enemas until after highest IVH risk period, reflecting cautious timing in the most fragile infants. This slide highlights several distinctive clinical practices for the management of periviable infants in Japan, as reported in our nationwide survey. Many of these practices have been covered in today's presentation, including cut cord milking, immediate intubation at birth, transition from CMV to HFOV, frequent ultrasound monitoring, sedation, probiotic use, and routine glycerin enemas. For additional details on practices not discussed today, please refer to the published article. This slide summarizes the broader bundle of Japanese practices. These patterns may help explain survival differences, but also raise questions about long-term outcomes. How is Ryu doing recently? His parents kindly provided the videos for today's presentation. He is now almost 3 years old. Please take a look. Does he look happy? To be honest, as physicians, it can be difficult to fully appreciate a child's day-to-day life because we only see them briefly during clinic visits. So far, he appears to be doing well, without any respiratory support and without requiring extensive support from his family. How are extremely preterm infants followed up? This slide shows the recommended follow-up schedule for high-risk children in Japan. In Japan, follow-up care is primarily provided by neonatologists in outpatient clinics, with assessment of development and other long-term issues. Neurodevelopment is evaluated at 18 months corrected age and at 3 years of age using the Kyoto scale of psychological development. Cognitive function is assessed using the Wechsler Intelligence Scale for children at 6 and 9 years of age. Throughout the follow-up period, we provide multidisciplinary support, including physical therapy, speech therapy, occupational therapy, and social skill training. Follow-up is not only testing, it is also long-term support for children and families. Continuity of care is a key strength of the Japanese system. How has you been doing after discharge? This slide shows how his long-term developmental outcomes assessed at 18-month corrected age using the Kyoto scale of psychological development. His total DQ was 75, indicating borderline to below average development. Therefore, at 18 months of corrected age, his outcome did not meet the definition of intact survival. This case illustrates that survival does not necessarily mean intact survival. Early developmental assessment provides important signals for later support. This slide shows in-hospital survival and the rates of severe neurodevelopmental impairment among extremely preterm infants in our NICU. Although there was no in-hospital mortality among infants born at 22 to 23 weeks of gestation, the rate of intact survival at 6 years of age remained below 50%. Our data show excellent in-hospital survival, but intact survival at school age remains limited, highlighting the need to focus on long-term outcomes. Recently, Hono and colleagues reported intact survival rates defined as survival without moderate or severe neurodevelopmental impairment using a cohort with a 90% follow-up rate. As shown, intact survival rates for infants born at 22 and 23 weeks of gestation were approximately 30% and 50%, respectively, and remain limited. In Japan, the focus of discussion has shifted from improving survival alone to enhancing intact survival and quality of life for their extremely preterm infants and their families. These national data reinforce the message that intact survival remains challenging. The field is shifting toward the quality of life and the family-centered outcomes. That concludes my presentation. Thank you very much for your attention. I will close with this key message. Improving survival is not enough. We must improve intact survival and long-term well-being. Thank you very much.
Thank you very much for that, Dr. Fumi. That was fantastic. And we have some questions here in the chat. The first one is from Lindsay, and she has asked, how often do you encounter challenges with mask size selection and availability for extremely preterm neonates during resuscitation?
So you mean the size for these periviable infants?
Mm-hmm.
We don't have difficulties to choose mask for periviable infants. So we always have, I don't know how many this tiny mask we have, but we already have the smallest mask for these kind of tiny babies. So we don't have trouble to choose them.
Okay. And another question from Lindsay, she has asked, what are the best practices to minimize skin or tissue damage from fixation of devices, like nasal cannulas in extremely preterm neonates?
Yeah, I think that many people ask me very often, but it's difficult to explain such a short time, and we always ask the nurses to keep this immature skin intact. So please email me, and I will ask my nurses and send back to her or him. Okay, sorry.
That's great. Another question from Padmesh, who has asked, how are repeat doses of surfactant decided?
Say again, how?
How are repeat doses of surfactant decided?
Okay, it's also a difficult question. So if the ventilatory setting is going up, like for example, FiO2 going up to more than 40%, we try to do something, try to do some intervention for infants. So one of them is a surfactant replacement therapy, and of course, steroid use or changing the enterotracheal tube size to bigger one. But at first, if I was going up to more than 40%, and the chest X-ray showed the RDS, respiratory distress syndrome, like with air bronchogram, and we decide to give surfactant to him. And in some NICUs, we Japanese neonatologists test perform a stable microbubble test, which can show us the volume of surfactant levels. And if the test is negative, we give surfactant to them. But in our center, we don't check the surfactant level, just FiO2 and chest X-ray. Yeah, we give it to them.
That's great. And I'll just finish with one final question from Dr. Tim, who has asked, in the UK, we avoid routine sedation for extreme preterm intubated babies. We worry that sedatives in animal models may be neurotoxic to developing brain. Have some in Japan thought about reducing or avoiding sedation to see if it helps long-term neuro outcomes?
Yeah, this question also many people ask the answer to this kind of question. So always I answered. So yeah, he mentioned in animal models, the sedation using a phenobarbital is not good for neurodevelopmental outcome. But in Japan, historically, we use it, phenobarbital for sedation during the first 3 days to prevent IVH. And the outcome is not bad. So we continue to do this practice since a long time ago. So yeah, that's my answer.
That's great. I'm just going to hand back over to Emma now for some closing remarks, but thank you very much for answering the audience questions.
Thank you so much, Dr. Fumi. That was a fantastic presentation. I know that certainly I learned a lot, and I'm sure that our audience will have enjoyed that presentation and the great detail and examples that you gave. We really, really appreciate it. So yeah, thank you so much, everybody, for attending our webinar. Apologies again for the technical difficulties that we experienced. We put up at the end a little QR code, so if you would like to provide any feedback, suggestions of topics that you might like to hear about in the future, please do that. I know there's maybe some other questions as well that people had, so if you want to put that into the feedback form, we can try and get you answers for those questions also. So yes, thank you so much for coming. Thank you for attending our event. We really